Shoulder pain is an interesting one because there are a lot of people who've had shoulder surgery before their Parkinson's was diagnosed. And it's not necessarily the case that it wasn't needed, but the Parkinson's might have really contributed to the shoulder problem because of the rigidity and the lack of movement. And then the mechanics were changed, and then it caused irritation and inflammation. So that may be it.
When you're talking shoulder pain, like, see, I have pain way back here, but what shoulder are you talking about?
We're talking about the shoulder joint itself. There are a lot of people who end up having shoulder surgery and then they're diagnosed. Not that they're not. I've seen a lot of people who've had neck surgery and then been diagnosed, but so it can be misdiagnosed as these things, and that's what you'll see in the Parkinson's literature, in the neurology literature. But I'm in neurology and in rehab, so I see both of those literatures. And I think it's not that. I think the case is most likely that there is some inflammation and there are underlying problems there. It's just the Parkinson's needed to be managed too. So with shoulder pain, trying to address the rigidity if there is that, or lack of movement is a good idea. Everybody should try non-surgical interventions for shoulder issues first, and just realize that there's more playing into it. So back pain also more common in Parkinson's disease. I think the contributors are very similar to what I was saying before, the lack of movement, the postural changes. The thing is that once those tissues are irritated, they're just irritated. It doesn't matter how a tissue gets irritated. It could be from somebody without Parkinson's who falls. Once it's irritated, it's irritated. So I think part of the reason that treating the Parkinson itself doesn't necessarily improve that back pain once it started that well is because the Parkinson's might have contributed to the onset, but once it's there, it's maintained on its own. So they all contribute to each other. There are some reports. This was the Parkinson's Alliance that did a survey of quite a few. This doesn't work anymore, but of a large number, I think 354 people with Parkinson's, some with DBS and some who hadn't, about whether, about their pain in general. It's a big report. And in this case, maybe a third or more of them thought that that Cinemat or dopamine medicine did help their back pain. So this, you may or not have seen at this point. This is camptocormia, and that's an excessive forward flexion of the body. It's not. These pictures demonstrate that it's not fixed. When you see someone like that, most physicians would think that's ankylosing spondylitis and that's fixed. The spine is bowed and it's all kind of ossified, and the person's going to be stuck like that. But in fact, when they press themselves up or lay down, they can get straight or almost straight. So it's a tipping that happens only when you're vertical. And that's a very frustrating problem for people, and no one quite understands what it is because it's seen. It's not just in Parkinson's; it's seen in muscle disorders and MS and motor neuron diseases like ALS after drug reactions. So there's this big argument in the literature. It's a muscle problem. No, it's a nerve problem. No, it's a muscle problem. No, it's a nerve problem. It's dystonia. No, it's not dystonia. So the jury is still out on what it is. And the estimates, I would not get worried about this, of prevalence in Parkinson's disease. Just not that many people have bothered to estimate it. And so I think that estimate's quite high, and that's because this was like Baylor, where Dr. Jankovic is, and everybody goes down there because they have something, unusual for him to look at. And so I think that's probably very high, this 6 to 12.2%. We certainly don't see that clinically. But generally it occurs later in the disease, but it may happen rather quickly. And it can be painful, as you might imagine. It also can impair your balance. Your center of gravity is way over. So people try, anything really, physical therapy, acupuncture, yoga. What I've seen most successful for people is using ski poles that kind of hoist them up and make them get up high. I know people wear backpacks with weights on them and do all kinds of things, but it's just really tough. It's unlikely that adjusting the levodopa or the Parkinson's meds really makes a difference. And then these oral spasm medicines or anti-dystonia medicines don't really seem to help, but they're worth trying. There are some people who have benefited from botulinum toxin injections, but I wouldn't run to do it because I don't think that many people really get much benefit, and they shoot you up and down your belly. So yeah, it's a lot of poking for very little benefit, I think. But DBS, I said isolated reports because that's when I first wrote this. There were just a few, but as I kind of updated it, there are more and more reports that even with both the subthalamic nucleus and the GPI globus pallidus, that maybe that can help. And then spinal surgery, there are some cases of successful spinal surgery. That really has to be if somebody's does definitely have other problems like spinal stenosis or bad a component of bad scoliosis. You wouldn't want to do surgery just because you're flopping over. And there are a lot of complications in those surgeries. So neuritic or radicular pain, so is saying that's in the territory of one of the peripheral nerves, like the median nerve or the ulnar nerve, or in a nerve root territory, as you see with sciatica. So that can be quite high. Now, part of it's because Parkinson's tends to happen to people as they get into middle age and older, and back pain is common. If you have a spine and you're upright, you're probably going to have back pain at some point in your life. You're going to have some wear and tear on your spine. And as I said before, the Parkinson's compounds it. But it may be compounded by the postural abnormalities, drug-induced dyskinesias, and rigidity. And then that might lead to some compression. If you're over to one side, you may. Oh, thanks. Okay. Let me. In the microphone. Am I fading? Yeah. Oh, okay. This is going too. I'll be pantomime. Okay. I'm going to have to hand you that for a second. So, can I advance this? Let's see. So, with these sorts of problems, the evaluation has to be just a standard evaluation for nerve pain or nerve root irritation, with the added need to optimize the Parkinson's medicine, at least make sure that people aren't undertreated for the rigidity. Tremor may also have a little bit of an effect, on the nerves if it's out of control. I put this in here because it's interesting, but dyskinesias are really hard to control, to manage, other than manipulating the medicines, changing the timing, decreasing the pulsatile nature of the medication. There are a few medicines that can dampen them, such as amantadine, but morphine is listed as something that might help with the dyskinesias and help with pain. It's just, again, that medical providers are reluctant to give that kind of medicine, I think, to people. So, do you have any questions there? Should I stop for a minute? Is there anything burning? Or can I go on? Are you with me? Yeah.
So I take it exercise or acupuncture or even cortisone would be recommended.
Yeah, but just the standard things that we would do for anybody with pain. The only added thing is to really recognize that the Parkinson's might be adding into it. I see a lot of people with Parkinson's to manage the medications and the rehab issues, and it's not uncommon for people to prefer to be a little undertreated at first because they don't want to be on too many medicines, and it's understandable. But sometimes it's actually potentially causing some trouble by compounding the rigid, just kind of creating a secondary problem potentially to be that sparing.
But am I sort of hearing that if this is Parkinson based or Parkinson related, that none of those conservative treatments will ever really work.
No, that's not true. Because if Parkinson's might cause might contribute to the irritation of a tissue. For example, let's say the shoulder, but it still may respond to. It still has inflammation. It may respond to a steroid injection, which is an anti-inflammatory. It might respond to range of motion. And what I'm saying is the added thing is we need to also try to address the Parkinson's component if it's not well treated. You know, unpeel that layer also. So, so the dystonia I was talking about, that's this kind of forceful, involuntary twisting. It can be kind of subtle, and that may happen early, especially in young onset Parkinson's. But it might come on later. Nobody understands dystonia, the physiology of it. Sometimes the medicines help, and sometimes they make it worse. Sometimes the surgery helps, DBS, and sometimes it makes it worse. It's very poorly understood. So, in general, off-period dystonia tends to affect the feet, such as people at night having foot cramping or first thing in the morning, foot turning in and down. When it's drug-induced, the observation is that might be more likely to happen in the neck, like a cervical dystonia, or in the facial muscles.
Which drugs induce it?
Any of all of them. So Cinemat, Mirapex. I haven't really seen that though. I mean, it can happen, but I think that's unusual. And when it happens in the DVS, it's often because there's spread of the current into the motor strip area, into motor fibers.
So if you're having foot cramps, is that without twisting, is that considered dystonia?
That's a hard one. It might be. You know, dystonia electrically is firing of multiple muscles at the same time around a joint. It's the agonist and antagonist. So if I was going to flex my elbow, really just my biceps should work and my triceps should relax. But in dystonia, they might both fire at the same time, but one's a little bit stronger than the other, so it ends up a little bit in flexion. And so you could listen with an EMG, an electromyographic recording, and tell if they're both firing together. You could figure that out. But you know, people do get muscle pain cramps that are more related to just like the calcium balance or magnesium balance in their system, and so that not all cramps are dystonia. The reason I have these here, you know, and I've given this talk to medical providers also, is that some of these things, that's a kind of hand somebody might have in rheumatoid arthritis, so it can be misdiagnosed. It's a dystonia, and the foot, although the foot tends to come in and down, just little weird things like a toe going down or going up can happen. So if it's an early morning dystonia, a lot of people just get up and walk around, and that's all they need. But sometimes they need to take their medications, and then it resolves. Sometimes we'll try to give it at night, especially if it's happening like in the very early hours, like 2 or 3 in the morning. We might give more medicine at night to see if that will help. Some people have